Thank you for the opportunity to talk with you about the interdisciplinary mobility team approach to reduction of facility-acquired pressure ulcers. Our team consists of 3 members from the College of Nursing, myself, Tracy Yap, Susan Kennerly, and Elaine Miller. Then we also have Dr. Jay Kim from the College of Engineering and Dr. Ralph Buncher from Environmental Health, who is our statistician on this project. There are 4 objectives for this presentation. First, I want to introduce you to the premise behind pressure ulcer prevention, and then explain the aims, outcomes, and impact of our prevention program. And finally, discuss the implications for future research. I'm showing you these pictures to demonstrate to you why our team believes that everyone has the right to an ulcer-free stay. That is quality care. And so what can be done to reduce the risk of developing a pressure ulcer? Well, among other things, our team believes regular movement is key. Standards and prevention programs are in place. However, the incidence and prevalence of pressure ulcers in the United States remains high at 24 to 28%. Our team thought that the problem was the consistency within the program. So the purpose of this study really was to improve quality outcomes by reducing pressure ulcers. Through a nurse-led, multidisciplinary approach, we will reduce facility-acquired pressure ulcers by 50% by increasing the mobility and movement of the residents within the long-term care setting. We used the team concept, turn everyone and move. This picture actually shows one of our posters that was placed at facilities to have a summary of the program while also acknowledging the team members at that particular facility. The concept of this program is very simple. Music is played for 12 hours during the daytime, every 2 hours. So when you hear, as a staff member or a family member, when you hear the music, you then move the resident, either by shifting their weight in the chair, getting them up to stand. And it involves multidisciplinary. So everyone within the long-term care setting can be involved in this. And then you basically document. That's it. So this was a quasi-experimental clinical trial design. We had 11 facilities out of 65 that were owned by Signature Healthcare. We used both rural and urban, all within the state of Kentucky. We started the study with 4 intervention facilities. 6 months into the study, we folded in another 4 facilities that served as a control up until that point. And 3 of the facilities remained as pseudo-control sites. Here you see our timeline, which included 3 phases. We're currently finishing the analysis portion of Phase 3. I'm going to speak very briefly about these phases and what was involved. So in Phase 1, obviously we formed an alliance between stakeholders and us as researchers, and we developed an IRB consenting training module for all those individuals in the facility that would be consenting residents so that they were IRB compliant. We established the skin champions and their roles. We established the nurse-led mobility team approach. We developed an education training program as well as a video that went along with it. And we designed the stimulus prompt, the musical overhead prompt, and decided on software. We also designed the mobility log sheets and the procedure manuals. We recorded and tracked mobility of the residents throughout the study. Then we developed all our databases. Now, keep in mind we had MDS 2.0 switched over to 3.0 in November of this year. So we had 2 databases designed and developed for that. We also had mobility log data and pre-post test educational training data. We installed the stimulus prompts into 8 of the long-term care facilities. We ran into a lot of difficulty with antiquated intercom systems, and this is actually prevalent throughout long-term care in the United States. So we ended up with 8 facilities that were able to actually have the intervention, and 3 of the facilities then served as pseudo-controls. We had whiteboards and mounted them in mobility logbooks at these sites. We conducted training sessions with staff and the mobility champions, designed badges, educational brochures for both staff and family, as well as posters for displaying. So phase 2 of the study was then the intervention phase, which launched in May and ran until April of this year. We had 10 new songs each month at the facilities. Both staff and residents picked in most facilities. And we had monthly site visits. Initially, because a lot of these were rural sites, 4 hours out of the city, we thought that monthly phone calls might suffice, but very quickly realized that we wanted to do the monthly site visits and change the music out at that time and have a look at what was going on. And then we also did refresher training. So we're currently in phase 3 of the study, which is all about evaluation, and there are 4 key elements to the evaluation. We noticed very early on that there was a distinct nursing culture. However, there wasn't a tool out there that would allow for examination of it, so we developed one. We administered the tool at the end of the study to help us explain the differences across these facilities. Also in this phase 3, we conducted focus groups, both with administration and staff at all the intervention sites. We have encouraged the continuation of the prevention program, and we had 4 of the 8 facilities that have kept the program going. And then we are in the process of conducting the final analysis. Okay, first I want to talk about the impact of the program from the perspective of the intervention. We had 2 intervention foci. The first was to create the multidisciplinary team. So initially we thought because the CNAs do 90% of the hands-on care that they would be our champions. However, it really was a mixture of RNs, LPNs, and CNAs that coordinated the program. And not all the facilities included other disciplines in the mobility team, although we strongly encouraged it. We had a few that it really ended up still landing in nursing's lap. But the teams were more successful when other disciplines were involved, such as maintenance and chaplains. And I'll give you an example. We had in our focus group evaluation one lady who had been a housekeeper who actually switched and became a CNA based on this program because she didn't just want to verbally remind the residents to move or get up and do their walk. She actually wanted to touch. She wanted to be involved more intimately, so she became a CNA. Another example would be a maintenance man who has 2 fellows, 2 residents who, as soon as the music come on, they run to find him and follow him around. So the program really was effective that way in terms of the multidisciplinary team. And then we wanted to introduce the musical prompt reminder. And we know, because of the focus groups, the music really was an effective cue. A secondary effect to the music was that it brought happiness to both staff and residents. More than just a reminder, it actually improved everybody's mood. And an unanticipated effect was that some music caused anxiety. Alzheimer patients in particular were negatively affected by classical music. Next, we'll talk about the impact from the specific aims of the program. And our first goal was to increase the mobility of the residents. Because this was a 12-month project with over 1,000 residents that ran for 12 hours a day, 7 days a week, this is going to take some time to analyze, and we're not quite there yet. What we do know is at this time is that everyone was more aware of the need to move the residents. Then the second specific aim was to decrease pressure ulcer incidence. And the number of new pressure ulcers actually did decrease. and the staff's perception is that the program was responsible. This slide shows that the percent of new pressure ulcers developed each month in both the treatment and the control facilities. So as you can see, over the course of the program from May to April, there was a sustained decline in the number of pressure ulcers. Once the control group joined in October, control facilities experienced that same sustained decline in pressure ulcers. On this slide, we have used the CMS quality indicator and quality measure data to compare the treatment group to the state and national averages. This slide shows that the high-risk patients were less likely to develop a pressure ulcer in our study. Now, the gap of data that you see here between December and January is due to the Centers for Medicare and Medicaid. They stopped collection of quality indicator and measure data for 2 months with the transition from MDS 2.0 to 3.0. So therefore, that's the missing data on this graph. A logistical regression analysis was performed using MDS 2.0 data to ascertain what in the first 5 months of this study predicts the development of a new pressure ulcer. As I said, we're not at the 3.0 data analysis yet. You can see that individuals with an indwelling catheter were actually 6 times more likely to get a pressure ulcer than an individual who does not have an indwelling catheter. Other variables that would lead to a pressure ulcer were being totally dependent and having to be transferred, the number of ER visits, and the number of new medications in the last 90 days. Then you're more likely to develop a pressure ulcer. Now, it's worth noting here that in MDS 3.0, the number of ER visits and the number of new medications actually aren't included. So this, again, complicates analysis. The logistical regression that was performed also helped to identify who is less likely to develop a pressure ulcer. Now notice this last one here. One thing our team believed was that if we got individuals to even just move by shifting their weight in the chair, that they would be less likely to develop a pressure ulcer. Obviously, you need balance to do that, and this is reflected in the regression results. So we typically think of this list as being associated with the development of a pressure ulcer. However, we did not find this to be the case in our analysis of MDS 2.0. So, as I said, we think about frequently bladder incontinence, bowel incontinence, pads, gender as being associated with the development, but that doesn't seem to be the case here. The results so far from this analysis leave us with some implications for future research. We need to investigate the challenges to the traditional thinking about variables, such as bladder incontinence and the use of pads and briefs. We need to examine the impact of nursing culture on pressure ulcer prevention. Throughout this study, nursing culture seemed to be very important to whether guidelines and standards were even being implemented. Therefore, we need to examine the impact of nursing culture on pressure ulcer prevention, or really any quality indicator measure for that fact. And then we need to study the association between developing a new pressure ulcer and out-of-facility visits, whether they're social activities or ER or medical visits, as well as the number of medications and the association between pressure ulcers. Thank you.